All right, so there was our intro video. I am Dr. Brooke. I am the owner dentist of your Special Smiles, and a special thank you to Emma for having us here today for this panel discussion. She's done a lot of work to help put this together for you guys. She's done a lot of work to start the Student Special Care Dental Association at your school. So thank you, Emma, for all you're doing for our patients and for what you're doing for your fellow classmates and for including us in that. I would like to give a virtual round of applause for her. So there we go to Emma for putting all this together. That is a lot of work, and we do appreciate it. Hey, someone's got the clap emoji. We've got an expert on our hands here. Also, thank you to all of you guys for being here. As dental students, your lives are busy, your lives are stressful, and there is probably 37 other things you could be doing with your time right now. And we appreciate you being here. And it shows a lot of dedication that you have to all of the patients that we love, that you're here to learn about this stuff when you do have a lot of other stuff to do. So we acknowledge that. We appreciate your time, and we're glad you're here. I also want to thank Dr. Costin for helping put this together and introducing myself to Emma. I've got so many great panelists. All of them are personal friends of mine. I am very proud of every panelist on this board, and you guys submitted questions to me. I read through all those questions. Those were great questions. We've assigned questions to each panelist, and each panelist will have 2 minutes to answer those questions. And so I will go ahead and start with the questions here. I have my fancy iPhone 2-minute timer I just discovered. And the first question is, do you think it is best to have parents of the patients in the operatory? And this question we have given to Karen. So go ahead, Karen, you have 2 minutes.
Okay. So I think it's very helpful for the initial appointment to have questions answered. I ask questions like the dental history, what works and what hasn't worked in the past, the medical history, the consents, patients' likes and dislikes, their social history, a little bit about if they have triggers, if they have seizures, what the triggers are, if they have autism, what type of sensory issues. And behavioral management techniques. But if patients are not part of the treatment team and cause the patient anxiety, or I would have them wait outside. Most of the time the parents are really a good part of the treatment team. And it's been very successful. Also in the past, there's usually one parent that is better to be a treatment part of the treatment team than the other. But I would say it really depends on the parent. But I think the initial appointment is vital for the parents to be there.
Well, excellent. You guys heard a lot of good answers there from Karen. She hit on a ton of high points that not every patient is the same. So some patients are going to react very well to their parents, and some patients that's going to not be very helpful. And I think that she's absolutely right that with that expertise she has there, knowing to say, yeah, this is working well and that isn't. So excellent answer, Karen. Our next question that you guys have submitted to us is, as a general dentist, when is it appropriate to refer a patient who you are not comfortable treating? Where would you refer this patient if you do not feel comfortable treating this patient? And our first panelist to answer this question is Jacob. So Dr. Jacob Dent, you have 2 minutes.
All right. So as far as when do you refer? I refer as soon as I feel like, it's outside of the scope of practice that I have. So, for example, if I have a 2-year-old with a mouthful of decay, the disability is not my problem. The restorative is my problem. So I refer out to any pediatric dentist that can do the work better than I can. As far as dealing with the behaviors or just the disabilities, fortunately or unfortunately, I am kind of the last person that people refer to. So I'd love to tell you, there's something else that's better out there, but there's a lot of people that are, especially our adult population, that are in need of desensitization, which is kind of my specialty, but there are some that are just really better served by sedation and in a hospital setting, depending on their disability or their health history. So I would say find a local dentist who has hospital privileges that works with special needs and kind of partner with them, or go to the dental school, go to the local hospitals and see who has privileges. Unfortunately, as a general dentist, even in my, years of experience, I don't have hospital privileges. So I can't go to a hospital and do anything if it's outside of the scope of my practice. So pediatrics are great for the little ones, hospital dentistry, great for the adults. But everybody else is just behavior management. General dentist should be able to manage that, or at least take care of the basics for that person.
An excellent answer. And I think that that's key. What he said was, as soon as it's outside of what he feels comfortable in his scope of practice, that's when he refers, just like with any other procedure. And so with that, another thing that I do with patients when I'm trying to test and see how comfortable I am, because when you're new at treating patients who have disabilities and you don't know where that comfort level lies, is what I'll do is I'll start with just, can I get them to sit in the chair? Oh, awesome. I can get them to sit in the chair. Well, now can I get them to let me touch their face? Awesome. I can touch their face. Now, can I touch their lips? Now, can I touch their teeth? Now, can I get them to stick out their tongue? Can I touch their tongue? Then can we do x-rays? And then we'll start with a prophy. I like to do just a rubber cup prophy and see how do they react to that. And then we're going to introduce something a little more sharp, like a scaler. From there, we're going to introduce topical anesthetic, something that's going to make their mouth feel different than they've ever felt before. And so we just take this gradual stepwise process, and that's kind of similar to what Dr. Dent was talking about with desensitization. Check out Dr. Dent's classes on Elevate, and we will send you some links for that. He's got some great classes on that. But those are excellent answers. And our next question we have here is, how do you reach patients that are in group homes? And for our first panelist to answer that question, we have Maureen.
Hi, guys. So every state will have some sort of agency for people with disabilities. So you need to find out what that agency is in your state. Like in Arizona, we have the Department of Developmental Disabilities. New York has a similar thing. So each state has one of those. So you need to connect with that agency and get on their list of dentists. They usually have a list of dentists, and let them know that you are willing to see these folks. And the group homes, because patients all have a social worker and a person that's registered with the state to sort of supervise and help them, the group homes will be connected. So that's the first place I would go. And then there's lots of larger sort of voluntary agencies like the ARC. And the ARC, there's an ARC, A-R-C, in every state. So it'd be like the ARC of Illinois, and you can find out where they are. Special Olympics is a great way to connect. Lots and lots of folks in group homes are working with Special Olympics and Healthy Athletes, Healthy Smiles. So these are some of the ways in the community that you can get your name out. And let me tell you that once one family, one group home knows that you are willing to see patients with developmental disabilities, you don't have to worry anymore, because they all know one another. And soon they will be knocking down your door and flocking to your clinic and saying, hey, can you see more patients? It's a network that people really, word of mouth is huge. People all know each other. Group homes know each other. The agency folks know each other. And I will tell you, all the parents know each other. So once you're seeing one, you're going to see them all.
Excellent answer. That's absolutely correct. And just like she said, they will come flocking to you, because a lot of them have requirements that they have to have these needs met. And a lot of them have a hard time finding people to meet those needs. And so they hear about you, and it is like they just heard the information that everybody wants to know. So we do about this much marketing in our practice, because all they have to do is say, oh, she said yes. Well, then yes, I would like to have her. So that is an excellent answer. So our next question is, how do you recommend asking caregivers to come to appointments to help them understand oral hygiene? And the panelist selected for this question is Dr. Dent. Go ahead, Jacob.
So with parents, caregivers, I make it mandatory that they come to the first visit. I don't want to see, grandma, if grandma's never brushed the teeth of the child before, or, don't send a driver from a group home if that's not the person that's helping them at the home. So it's imperative that we get these individuals who are doing the self-help care for our special needs patients, kids or adults, to be part of that. So I kind of have a good rule that says, new person, new environment is going to give you a bad result. So what I do is I actually let the parent or the caregiver be the dentist the first time they come in my practice. And what that does is it shows me what struggles they are actually having at home, because people will lie to you. They'll tell you it's going great. And it's just a bold face, lie. So, cause they don't want to be judged. So I let them tell me, hey, it's going great. And I said, great, show me. So as soon as it turns into some kind of WrestleMania match in the front of my office, I know we got some work to do. So it's really good for you as the dentist, because all of a sudden now you're the coach, you're the person that's trying to help them, instead of the parent looking at you when the child or the adult has a meltdown and they're looking at you as a bad dentist. So I tell them, just because you're not able to brush their teeth at home, I don't look at you as a bad parent. So let's kind of formulate a team effort here. So very much it comes down to whoever is in charge of that. I want them at the appointment, and it's a mandatory first visit, because I know what I can do, and there's not much I can't do, but I need to make sure that the other, days of the year when they're not in my office, that they're taken care of.
Excellent answer. And I think that he's spot on with that, because it does establish that trust, and it establishes that teamwork style feel versus, hey, you're the dentist, it's your responsibility to just make sure this person's healthy. I really like that. And that was actually something after taking Dr. Dent's course on Elevate that I started doing as well. That's something that I had never thought of and that I learned from him. So thank you for that answer, because these guys can now learn it as students, and I learned it after I'd been practicing special care for like 4 years. So thank you for that. So the next question is, what do you do if you suspect that someone has special needs, but they have not disclosed anything on their medical history? We have two panelists answering this question. And first, we're going to go ahead and Dr. Jensen, you are up. So go ahead, Melinda.
All right. And this is a fantastic question, because I know that some people do narrow their scope of practice to just special needs, but I work in a public health clinic. So I see anyone and everyone that walks through my door. And there are many people that come in and will do our standard medical history that doesn't ask really specific questions about disabilities. And you have to take every person as a unique individual. So they come in. I'm so blessed that where I sit in our little office, I can kind of hear what's going on in the front office, and I can kind of hear what's going on in the back office. So with every single patient, I'm constantly listening and saying, okay, how is their experience at the front office? Are there any behaviors going on in the front office? What's going on when they get back to the back office and get seated? For those patients who come in and may struggle a little bit, honestly, we work through it the best that we can and are cognizant throughout the entire process. So just things to remember, everyone that comes in is unique. Some have disabilities that are easy to see. Some have mental health issues, cognitive issues, that are a little more invisible sometimes to the majority of the public. I honestly believe that, and I know I'm running out of time, that there are a lot of adults in our community that struggled as children. I know I'm going over, Brooke, I'm so sorry.
No, you're okay. You're totally okay.
With the new testing techniques, that would be technically considered special needs. And they've also been through enough of life and enough of those situations that they have learned to mask some of those behaviors. So it's also kind of getting them past what they're used to communicating and trying to draw out as much as you can. And I'll let the other panelists speak, and if they're okay with me chiming back in, I'll leave it at that for now.
Well, excellent. And with that, we will go over to Karen. And Karen, that was an excellent answer, by the way. And Karen, you are our next panelist, and go right ahead.
Okay, so what I usually do, and this is it's a common thing, is I go over the medical history, and I also look to see who is presenting with the patient. And I'll say, oh, what is your relationship? And they'll say, oh, well, that's a caregiver, or oh, this is who it is. And you can find out information from that. I can go over the medical history, Look at some of the medications. That'll kind of, if they have some psych issues, there'll be some psych meds. Another thing is I will ask them, how did you find our office? Were you referred? And they'll say, well, I went to this office, and, you know, sometimes they'll give me a little bit more, they'll tell me, or I ask, do you work? What do you like to do? Do you go to school? And they'll be like, no, I go to program. And I find out a little bit more. We had actually had a patient come in, and a student was doing their competency on a special needs, and the patient was in a wheelchair. And the patient never filled out anything, but the student was afraid to ask why he's in a wheelchair. So I asked, he had muscular dystrophy. So sometimes questions like that. And if they will not tell you, my last thing that I would do, and I would recommend, is actually finding out what type of dental insurance they have, because some of our patients with disabilities have dental insurance, special kind. And if all else fails, I would do a med consult, and I would, you know, find out who their doctor is and send out a med consult, because sometimes patients are embarrassed, or in a small population, as Dr. Perry has always said, a small population of the older people actually don't have a clinical diagnosis. So those are some of the things that I have done in the past to try to figure it out. But when I ask them questions and interviewing them, I always do it in a very caring and compassionate way, so that they don't see it as a threat. They see it as, I really do care and I want to treat the whole person.
Excellent answer. And what I think we'll do for this question, I think you guys both hit on some key issues. I think asking those questions in a caring, compassionate way. Medical histories are my very best friend. I actually get them on all of my patients because I just like to see what their doctor has. And there are a lot of times you'll find someone who has heart problems that didn't put heart problems down because they had this heart surgery and now it's fixed in their mind. And so I like to review medical history on everyone. What I think we'll do for this question is we'll finish the rest of our questions and we will circle back, because I think what Dr. Jensen was talking about was really important. And I would like to get back to that. But just in efforts to get through all of the questions, for in case anybody does have to leave right on the hour, we'll go through those questions and then circle back. Our next question is, what does the first appointment look like for a new patient who you have never seen that has a disability? And for that question, I was actually going to answer. I'm going to start the timer on myself here because I don't know if I can see the person timing me. But for my first visits, I do something kind of unique. I do a teledental visit for the first visit. And so on a teledental visit, some of our patients interact with screens a little easier than they interact with people. And so we can do this teledental visit. They interact with me a little more comfortably. And then I can actually take them on a virtual visit of the office if my laptop is fully charged. If not, sometimes it can cut out in the middle of that. And so make sure your laptop's charged if you do that. But you can take them on a virtual visit so they can see where they're going before they come in. And I found that to be helpful. I can't always do that. And I work in various different locations, and in some of the locations I can do that, and some of the locations I can't do that. Sometimes I'll do a house call as the first visit where I go see them in an area that they're comfortable with. So then that way they recognize me when they come into the clinic. But in those situations where neither of which are possible, for a first visit, we just try to keep it happy, and we try to do exactly what we would do for any patient in a first visit. My goal is to get that comp exam done, but I know in my head that I'm probably not going to, or that I might not. And so we see, can we sit in the chair? Yes or no? You know, and we try for that. Can I touch your face? Can I touch your lips? Can I touch your teeth? Can I take x-rays? Can I use a prophy head? Can I use a scaler? You know, and we carry on as far as we can go until we think, or the caregiver thinks, because I always have them in the first visit as well, until someone thinks that they probably are about done. And we always end on happy, and we always end on them doing something I ask them to do. If they have a meltdown, that's not the end of the visit. After I let them have their meltdown, they finish with their meltdown, and afterwards I say, stand up, sit down, stand up, sit down, or high five, fist bump, high five, fist bump. They do those things, give them a prize, and then they leave. And what that does is that shows them that before you leave, you have to do something that I say. Your meltdown did not get you out of this visit. I mean, it kind of did, but you still have to do something that I ask before you can leave. And I made it. 9 seconds. So the next question is for patients who have mental or cognitive disability, what type of language do you use, and describe the procedures and to describe procedures and information to the patient. The first panelist we have for this is Melinda. So Dr. Jensen, go right ahead.
Wonderful. Great question. From the beginning of the appointment, again, even in the reception area, you kind of start to assess cognitive level. And then if you are lucky to have parents or caregivers with a patient, they can really help guide you. Sometimes I'll step away with the caregiver and say, tell me about, John or Jane. What's the best way to communicate? Do they have any signs that tell me that they're anxious or that they need a little mini break? Sometimes you'll have patients that come in. They are obviously physically disabled, but cognitively, they're sharp as a tack. And huge thing for me, if I do get to step aside with the caregiver and go over some of that medical history and some of their behavioral history, it's fantastic. But when you hit that operatory, I speak directly to the patient. They'll sometimes won't even look at me. They'll look down, they'll look at the window, they'll look at their hands, or if they have something with them that comforts them, they'll be looking at that. But other times you have people that come in who utilize other forms of communication and are so grateful that you made eye contact with them, that you were the main focus. And I've even had patients say at the end, thank you so much for talking to me, because I'm the one that's actually in control of this, of my health, my oral health in this appointment. So always remember that.
I think that is one of the best pieces of advice in special care dentistry. And thank you for that answer, because talking to your patient and treating your patient as a person, not as someone that belongs to the caregiver is such a key thing in special care and so key in establishing trust. So thank you, Dr. Jensen, for that. And the second, we have Maureen. So Mo, I think you are the second person to answer this question. Go right ahead. Oh, sorry.
Yeah, so thanks for stealing my thunder, Melinda. But that is the key. That is the takeaway. You have to treat people with respect and dignity. People are people, and that's really, really important. When people have a developmental disability, I don't speak to them like they're a child, because they're an adult. Okay, so we don't like baby talk, like, oh, how cute, oh, how sweet. God, please do not do that. It's like, can you imagine if someone did that to you as an adult? You'd be like, what is wrong with this person? Do they have a developmental disability? Why are they talking to me like that? I'm a grown person. So don't do that. I talk to people, but I talk to them simply. And I will ask a person to repeat to me after I tell them what we're doing. We're going to take x-rays. Here's what we're doing. And I'll tell them exactly the steps to take the x-ray. And I'll say, do you have questions? Can you tell me what we're going to do? And I'll want them to see if they really can understand what we're doing. Then I know if the person can really give consent, right? So I'll know if they can really tell me back what we're doing. Lots of people with developmental disabilities have something called acquiescence, where they just say yes to everything. They're like, how's everything? Good. You brushing your teeth? Yeah. I'm going to take a look. Is that okay? Yeah. And then you go to do it. And they're like, oh, no, I didn't know that's what that was entailing. So I always call those patients the yeah, no's. They're like, oh, yeah, sure. Everything's cool. I'm great. Yeah, oh, no, you're not looking at my mouth. So we see that a lot, and patients have acquiescence. So, you have to be kind of simple, direct, ask people to reply back. And another key thing is, I always ask people, if the caregiver tells me someone's nonverbal, I'll say, how did they make their needs known? How do you know if the person's in pain? How do you know if they're hungry? How do you know if they want to go to the bathroom? So they might do this. By the way, that's the ASL sign for bathroom. It's the sign for B. If you learn no other sign language, learn the sign language for the letter B, because it is largely used in the developmental disability community to signal that I have to go potty. So this is something important. Yeah.
Awesome. Awesome. You still had a lot of thunder to come back with. That was pretty good. Those were great answers. As always, I always learn a ton from Mo. So the next question is, how can we better prepare ourselves for treating patients who have special needs? And the first person we have answering that question is Sammy. So Sammy, Dr. Sammy, it is your turn.
Hi, everyone. So some of the main things I would say, and we touched on this a little bit earlier, is know your patient's medical history. Make sure you research the conditions ahead of time and all of their medications and their impact on dental treatment. And make sure to ask the patient really detailed questions about their history. They always tell us here at ASDO, never treat a stranger, and that couldn't be more true. Another thing I would say is to be a team player. You want to make sure you communicate with other members of the healthcare team. So med consults, contacting the physicians, social workers, anybody else who may be involved in the patient's healthcare. And know your patient's legal guardian or power of attorney, because we have papers that need to be signed and consents in dentistry. And so you want to know who's going to be signing those. Make sure you use people first language. So say a person with a disability instead of a disabled person, for example. Just make sure that they are a noun before they are the adjective that describes them. Or saying the patient uses a wheelchair instead of they are wheelchair bound. Just being politically correct in your terminology. Another thing is creating a calming environment. Make sure to ask the patient their favorite kind of music, talk about something they like, get to know them, so that you can have just one extra little bit of comfort and familiarity in the chair while you're treating them. Another thing you can use tell, show, do, positive reinforcement, any other methods to make their visit a little bit easier. And the last would be just to be patient and be flexible. Ride the waves as they come along and have fun with it, because it is really enjoyable. But you have to be flexible. You have to be able to change your plans on a dime and be okay with that and not stress about it and not convey that stress to your patient. So that's it.
I think she's like on the dot with the 2 minutes. You get a prize for that. I think it was like right there. The next person to ask about this is Dr. Dent. So go right ahead, Jacob. It is your turn.
Thanks. So Sammy, you had a great answer there. I think the only thing I would add to that would be do some pre-work as far as getting the patient comfortable with what's going to go on prior to coming in. So make a social story of your office. Brooke, you talked about walking them around on a teleconference. I make a social story with pictures of what we're going to do. I've got a sensory kit that I invented that I send out to the families before they come in. And it really is just one of those things where I want to, it helps identify those triggers before they even come to your office. So the more that you can do prior to the visit and know prior to the visit, the better that's going to go. Once the visit happens, like I said, you can have a room that's set up with sensory. I have an entire office that's sensory, but it really just kind of comes down to, like Sammy said, sometimes it's going to go so great. And sometimes it's going to turn into a giant shit show, if I can say that. But that's exactly what it is. But being a special needs dentist, you have to understand that you have to be, it's 90% emotional empathy, 10% dentist. And so for all the dental students on here, I guarantee you, out of all the panelists on here right now, everybody is a skilled dentist. That doesn't make us a great special needs dentist. Be a good human before you're a great dentist, and you'll do very well in this arena.
Excellent answer there. Yeah, those are all key points, and I think that gives you guys a lot of information. Dr. Dent did not tell you the name of his product, but I will. It's called the Brush and Bite, and you should check it out. It's really neat. It's sold on Triple Bristle, and we'll have a web link for that and a handout that I will send over to Emma. So it's a really cool product, and we do use it. So I know you didn't want to promote your own product, but I'll promote your product because I think it's awesome. The next question that we have here is, what do you recommend for talking to other dentists about patients that did not have the best care in their office. If a patient does not get proper care at one office, then comes to yours, and you know that what happened before was not right. And that question is for Maureen. So Dr. Perry, it is yours.
Yeah. So give everyone the benefit of the doubt. Okay. I will tell you that after practicing for 30 years, I sometimes see stuff and I'm like, that's an awful feeling. God, that's terrible. And then I realized like, it's mine. Like, oh, I'm being a little hard on myself there. Or, oh, I supervised that with a student. Why did I let that go? You don't know what went on that day, as Dr. Dent so eloquently put it. Sometimes patients have a bad day and things are going along well, and then all the wheels fall off and you're trying to get the filling in and the patient's squirming and there's water contamination and mom's having a fit and you're just like, oh God, I just got to get this over with. And that's what happened, right? It's not ideal. Okay. We're working on moving targets. These are not patients who are just going to be like, okay, open your mouth and sit there and I'll do your dentistry and you go home. Like, that's boring. Like I couldn't do that. When I was in private practice, I was like, there's no challenge to this. These people listen to what I'm doing. And they sit still. Like, what's the fun in this? So when you're doing special care dentistry, patients are really, you don't know what's happening. So you have to give them the benefit of the doubt. The other thing I will do is I use sort of a mentoring approach. I'll call people and I'll say, hey, this guy's here and tell me what happened. What was the experience? And then I'll also give them some resources and say, when that happens again, if you have a kid who has a whole meltdown, do what Dr. Brooke does, make sure they leave on a good note, but that you don't let them win. They never get to win because then you have lost control and you will never get them back in the chair. So I make sure, and I'll tell people, here are other resources. Here's Special Care Dentistry Association, here's AADMD, here are lists of places you can go to get educated and learn more about working with this population. Just don't assume that somebody's a bad dentist, okay? That's because you know what? It could happen to you and you wouldn't want that. You want them to think that, that's you, so.
That is a perfect answer. We had the hardest question for the person whose graduation year was the lowest graduation year. So the most experienced person gets the hardest question. And I do think that is probably one of the toughest questions on here. And she hit it right on the head. That was perfect because I've done the exact same thing. I have looked at work and I have thought, oh my gosh, who did this? And then I find out that it was me. And so you are not alone in that. That definitely does happen. And so the next question that we have is, does your treatment planning change based on the level of physical and cognitive abilities of the patient? And our first person to answer for this is going to be Melinda. So Dr. Jensen, here we go.
So I say yes and no. You're always held to the standard of care. Always. You are always responsible for those patients and their oral health and well-being. Having said that, so many of our patients do need to be sedated, and I do go in and do hospital dentistry, so I have that ability. So I look at how often I would like to see this patient. Have they been seen recently in the hospital for a more comprehensive view? Is the patient able to communicate discomfort? Has the caregiver, or if the patient is able to tell me, experienced something and reported it either to me or to their caregiver. I use a lot of silver diamine fluoride. It is a fantastic preventative. When I look and do exams on those who really are not able to cope with a true what we consider normal dental exam, I'm looking broadly. I've got my report, my chief complaint, if any, and I'm looking broadly at the patient. Do I see any swelling? Once I've gotten past, as Dr. Brooke mentioned, will they let me touch their lips? Will they open their mouth for me? Will they do a quick visual exam? I'm looking broadly. Do I see anything big? Do I see anything that I'm worried about that would indicate that they would need to go back into the hospital? So yes and no. Yes, I'm responsible. Sometimes SDF and a quick visual is all I can accomplish in that appointment, and then we bring them back.
Excellent answer. You just talked about my second favorite chemical on the planet. I love SDF. I think that bourbon is number 1, SDF is number 2. The next person to answer this question is Dr. Sammy.
So Dr. Melinda touched on a lot of this. My answer was also yes and no, that every patient, regardless of whether or not they have a disability, deserves an individualized treatment plan that's up to the highest standard of care that you're able to provide. However, treatment plans may change based on the patient's ability to care for their teeth, which is dependent not only on their physical and cognitive capabilities, but also on their home environment and the resources that they have. So these factors can affect a patient's ability to make it to and from appointments, to sit in the dental chair, and to perform at-home oral hygiene, which may affect how you do the treatment plan. So for example, patients with intellectual disabilities, depending on the extent, typically do not do too well with removable prosthetics. So it's often worth it to attempt to save teeth that would otherwise be considered hopeless in a lot of these circumstances. Additionally, just like Dr. Jensen had said, is if there is an extremely large amount of work to be done and you know that they have a little bit of difficulty sitting in a chair, or the patient's very anxious, then you may want to consider some type of anxiolysis or other modalities such as nitrous, oral sedation, or deep general sedation, or even physical supports if necessary, like a papoose. We try not to use our papoose too much in the clinic here, but we do have some patients who like it and they use it as a mode of comfort. So it's all situational.
Excellent. Excellent answer. Both of you guys just touched on it so well. You know, the ability to clean those prosthetics, the ability to use the prosthetics, the ability to make sure that your work is going to hold up. Those are all excellent, excellent answers. The next question that we have is, and this is going to be kind of the Dr. Melinda and Dr. Sammy show here at the end. I didn't do that on purpose, but that's just kind of how it worked out with assigning these questions. What are the biggest challenges that you have faced when treating patients who have special needs? And we'll go ahead and let Dr. Sammy just stay right on there and go first on this one.
So I guess the biggest challenge for me is that it is a very vulnerable population that you're working with, in which you may encounter some circumstances or situations of abuse or mental health disturbances. As dentists, we are mandated reporters, and if a patient does disclose any indication of domestic violence or suicidal thoughts, this is something that we must report to the authorities to ensure the safety of our patients. Occasionally, it can be really challenging to witness these types of situations, and it can be hard to see patients being mistreated, but it does happen, and we have to be ready for that. But we do have the power to get them the help that they may not have otherwise gotten. Which is why it's really so important to be in cohorts with the social worker and all of your team on this, or everyone on your healthcare team, because we are working with such a vulnerable population.
Excellent answer. And Dr. Melinda.
Oh, I agree completely. All my addendums are training, teaching, encouraging support staff. Because there is a level of unknown when you walk into working with special needs patients. I don't know what they're going to do. Am I going to hurt them? Am I going to do something wrong? And getting your support staff comfortable is not really that much of a challenge, but it is something that is going to take some of your time as the dentist, encouraging and mentoring. And the other, I'll be really honest, is paperwork. I'm not a paperwork fan to begin with. And patients that have special needs honestly come with a lot of paperwork. We talked a little bit about guardianship, paperwork. There's so many different pieces to the puzzle. Pre-authorizations, which don't seem like they should be needed, but they always are. Working with the different insurances, those are the struggles. When caregivers, when there's so much change for the patient and their caregivers are constantly changing, their whole world is turned upside down over and over and over again. And having them stable is one of the most important things that you can have for this patient. So those are the kinds of struggles. It's not the patient management part. that's the human part. That's the wonderful part. It's all the extraneous stuff that comes along with being privileged to serve special needs patients.
That was like one of the most beautiful answers I've ever heard. Like, I've got to clip that little thing of the recording out and put you on our Special Care Dentists of Idaho page saying that, because that was just gorgeous. So excellent job to both of you. That was great answers. Our final question that we have in the submitted questions, patients who have special needs, what is your favorite part of treating them? Sammy, go right ahead.
So I'll keep this one pretty brief, but my favorite part of working with this population is everything that they teach me. I think they just have a different perspective on the world than the rest of us. And despite all of the hardships that they face, they still come in with a happy, smiling face and are unapologetically happy and excited about the little things like we all need to be a little bit more of.
That is an excellent answer. And Karen. Oh, sorry. You get to have your 2 minutes too. Sorry about that.
Okay. I have to, whatever Sammy said, I kind of wrote the same thing. This is a great question. After 30 years of doing this, my favorite part of treating people with special needs is their unconditional love that they have taught me. They taught me to be a more kinder, compassionate, and be more comfortable with people. And they also taught me how to communicate better and be a better communicator. They taught me never to treat a disability or a disease, but to treat them as people, not to patronize them. They're very amazing people. They have very unique talents that I have come to learn, and they're very passionate about their things that they like. I may sound very selfish when I say this, but I especially love the way they make me feel. People don't forget how people make you feel. They make us feel respected, loved, and an important person. And the hugs, the fist bumps, and the high fives are just a bonus in my job. So I've got the best job in the world. I'm truly blessed because of them.
Well, and they are blessed to have you. Actually, Karen was one of my first contacts in special care dentistry. She is one of my mentors. I went down to A.T. Still University, and my dad's house was across the street, and I went down and I met her, and she's just absolutely phenomenal. I came home and I said, I just met the best hygienist. Like, she knows so much. She just taught me so much, and I was only with her for like an hour. So if you ever hear anything that she's doing, definitely listen to her. She's definitely worth listening to, because she has been awesome. That does conclude the submitted questions that you guys had. I would like to circle back to what Dr. Jensen was talking about with mental health issues. And then after that, we'll see if any other panelists have anything else they would like to add. Then we will jump into the questions, and we will let Emma take over the questions from there. Does everybody like that plan? Awesome. I got some yeses. So go ahead, Dr. Jensen, and finish up what you were talking about with the mental health issues, because I do think that was an important, and I did not want to jump over that.
No, and I'll kind of gloss over a little bit of that, and that is that you have people with behavioral health issues that are going to present and have their own set of special needs, just as you would have cognitive special needs or physical special needs, and just being very aware and constantly checking in and making sure throughout every aspect of the appointment, before and after even, that you're aware of what's going on with that patient, what their triggers are, et cetera. And I think other people have spoken to this as well. And I wanted to bring together a few things, and that is that we've talked about having parents of the patients in the operatory, bringing them in, teaching them oral hygiene, having people that are not disclosing things on their medical history. Dentistry is about relationships. It's about relationships. You can fix a lot of things. Anybody can fix a lot of things in the mouth, whatever, okay? you're dealing with a human being. You're dealing with their family, the ones who have protected that patient their entire life, who have them completely in their heart. You're dealing with caregivers who some have been with their patient for 30 plus years. I've had just amazing stories happen. You're not only building a relationship with a patient when you are treating special needs patients, you're treating the entire family. You're building trust. And that's really the heart of special care dentistry is going in and building those relationships, building the trust, and then so many things bear fruit.
Excellent, excellent answers. So any other panelists that'd like to add anything, go ahead and put your name in the chat, just so then that way we're not all talking at the same time. And if I don't see any names in the chat, then we will turn it over to Emma to take questions from everybody else. So Dr. Perry.
So, Melinda brings up a good point. And I think one of the things that people don't realize in private practice, and not that people just want to do special care, but once you see someone with special needs, they'll send their whole family. It's like, oh, well, they didn't kill that person, so I guess it's safe. We can send everyone else. And I say that, kind of in jest, but it happens all the time. And it is a tremendous way to build your practice, because people see the care that you've taken, the empathy that you've shown. They see the way that you communicate. As Melinda says, it's all about relationships. And they're like, you know what? I should bring my other kids here. You know what? I should come here. Boy, this place is better than my dentist. I should go here. And again, it's a tremendous private practice builder. So the time that you put forth in seeing a person with special needs, you might not see the return on investment from a financial standpoint right away, but you will see it. Okay. And there's models to prove it. And so, 20% of Americans have some sort of disability or are geriatric. Okay. So if you think you can pay off your student loans without seeing that group of people, good luck. You're going to have to see them because they're everywhere. So just get, it's a good way to do it. And I cannot tell you how much you will be rewarded, not just, in practice, but from having the hugs and the respect and the love of your patients. As Karen said, you'll never feel like you're going to work. It'll never feel like a job. You'll always feel blessed. So.
That is excellent. Any other panelists have anything to add? I'd like to point out Dr. Dent's wonderful suit that he has. If everybody can see his suit has money on his suit. And Dr. Dent, you have some things in your practice that you do to make this a little more financially viable in a private practice setting. Do you want to talk about that just a little bit before we jump into more questions? Not to put you on the spot, but
no, so there's kind of like everybody said, when it comes down to special needs, one of the struggles that we all face, especially when I teach my classes, I get it takes too long. We don't get paid for the extra time. I can see 3 neurotypicals in the same time it take me to see 1 special needs. Why would I do it? And to the kind of the point of that is, in my practice, I have associates that see my neurotypical patients. I see the special needs, but when you get into the flow of this and you're doing it enough, I kind of get to that stage where I'm seeing, on average, I see probably 18 to 20 special needs patients a day, which for most people, that's a year, if that, and I don't do any sedation. And so everything is just based off of the desensitization process and getting that. But it's kind of what Maureen was saying. If you treat a special needs child, a special needs adult in your private practice, I guarantee you that family is going to come to you as well. And, for every special needs child, like I have a son who's 17, who's on the spectrum. I also have a daughter who's neurotypical, who's 18, my wife, me, and we would go to any provider that'd be willing to see my son in addition to us. And so you want to build a private practice when you come out of school and you want to make it, financially sound, start treating this population, like Brooke said, I don't advertise anything, and I'll share this. I saw a family yesterday. I made a little post about it on my Facebook page, And y'all, I could do a full mouth restorative case that is the most beautiful God-given thing in dentistry. And I get 2 likes and yeah, that's nice. I made this one post just to kind of share about the special needs family. It's been shared like 59 times already in a day. It's like, I don't know why I went to dental school. I should have been more of like an emotional counselor, because that's what people need in this arena. So like I said, just be aware that when you're doing this, like I said, it's not work. I do a lot. I travel back and forth between Texas and Louisiana, and 18-hour days suck. That I travel for 9 hours, I work for 9 hours, but other than the driving, it's some of the best 9 hours of my life. I get to make a difference in people's lives, and people will thank you wholeheartedly for what you're doing, as opposed to nobody cares what type of tertiary anatomy you put in that filling. I guarantee you. So if anybody has any questions of what this looks like in private practice, y'all are more than welcome to reach out to me. I'll be happy to give you kind of the way I do it in my model.
And one more question for you before you get before we go to other questions, Dr. Denton, you and another panel had talked about not having to be trapped into taking Medicaid because you treat patients who have special needs. And that was something that was a surprise to me when I asked you that question in a different panel is, do you have to take Medicaid if you see patients who have special needs? And do people accept treatment even if you don't accept their insurance?
Yeah, I don't take Medicaid at all. And the reason is in the states of Louisiana and Texas, I can't limit Medicaid to just special needs. And obviously I'm not interested in flooding my practice with just every 2-year-old that happens to be on Medicaid. So unfortunately, that's just the nature of the program, the government program. Now, most of my group homes, they pay me in cash and they're refunded by the Medicaid program. So I just deal with them straight like that. But, like I said, I'm practicing in 2 states. I've got people that drive 3-4 hours one way just to come see me. And I guarantee you they pass up a lot of other people along the way. But, as a special needs parent, I will tell you, the money isn't the option, is the biggest hurdle that we face. It's finding the provider that we know is going to do the best for my son. And, that's what I try to provide. I try to be that person that everybody wants to come to because, I live in their shoes every day.
And those are excellent answers. And the reason that I asked some of those questions at the end was just to show the diversity that we have on this panel. We have people at an academic facility that's treating patients who have special needs. We have Dr. Dent, who actually does not take Medicaid and runs private practices in 2 different states. We have Dr. Jensen, who works at a federally qualified health center. We have Sammy, who has just graduated and is treating patients who have special needs in a residency. And I myself, I treat patients in a mobile clinic, and I do telehealth and hospital dentistry, as well as working in a health center. And we're now going to be building a special care clinic. So I'm pretty excited about that. And thank you all. Thank you all for listening. Thank you all as the panelists. Love you all. And I am so grateful that you guys are willing to be on this panel and to join us today, because I think that a lot of students are hearing a lot of good stuff from all of you panelists. So any of you that do have to go eat dinner, do not feel bad about that. If you need to go, if you're wanting to stay on, feel free to stay on and take more questions, but thank you all. And thank you, Emma. And Emma, the floor is yours.
One question that I did get was about for patients with special needs, how do you go about establishing that guardianship or like power of attorney for healthcare and stuff like that if you suspect that they don't understand, what you're saying, and that you question their ability to consent?
Can I answer, Brooke?
Absolutely.
I always say to patients, is there someone who helps you with your healthcare decisions? Do you have someone who when you're not sure what you should do, that you talk to them about it? And then I say, is it okay if I talk with that person, right? Because it's HIPAA. So you can't just go and talk to someone's mother if the person's an adult, even if they have a developmental disability, if the mother is not their guardian or the medical power of attorney. Okay, that's illegal. You can't do that. So I always say, who else are you, who do you talk to? Can I, and that's it. It's very simple.
What do you do when you suspect a patient has special needs, especially if they're like family or friends? So kind of like more of like a personal, how do you not do it disrespectfully, but also in a, way that where you want to help.
Anybody want to jump on that one?
Well, maybe because I've just been around a really long time, this happened to me. So our dental assistant has an adult son who was about, I don't know, 10, 12, he was about 10. And he had developmental disabilities. And then she had another baby. And like, she brought him to the clinic and he was about, I don't know, he was a couple months old. And he didn't make any eye contact. And then at 8 months, he didn't make any eye contact. And like at 1 year, like no eye contact. And we're like, So we're like, how's Lucas doing? And we could not get our dental assistant who works in special care, who has a son with special needs, to realize this. But of course she knew, she just didn't want to, she couldn't do it. So we're like, finally, we're like, should we do an intervention? How should we talk about it? And so finally one day I just said to her, so what's up with Lucas? Like, did you notice he doesn't really ever look at you? And she was like, yeah, about that. She's like, I know, I'm just like not ready. I'm just not there yet. And I was like, okay. So I kind of just said things that were obvious. Like, do you notice that your kid's toe walking and they're 5? Like, that's not normal. Like, especially if people have other kids, because it's not that the thought hasn't crossed their mind, because it usually has. And then it's like, hey, there are resources. So if you're going to have that conversation with someone, you've got to be prepared to tell them what they need to do next. You've got to say, like for us, we're like, U of A or Phoenix Children's Hospital has a program. You could get them evaluated. There might be special programs at school. They might need help in, with other programs that are available. So you need to not just be like, hey, this person has some sort of special need. You need to do something about it. Like, what should they do about it? You need to give them a resource so that they can move forward.
Another perfect answer from Mo. I am so glad that you came on, Mo. You are just fabulous, and I learn a ton from you every time that you talk.
Can you elaborate on what you do for oral hygiene for patients who are in a long-term comatose type state?
I could speak on that. I worked in hospital dentistry, and I also worked in a skilled nursing facility, and we had a lot of patients who were long-term comatose. And I also even at our school, we see people coming in with skilled nursing facilities that are in some comatose patients. And what I recommend is that a lot of them have suctions. And I actually have this with me, and it's called the plaque vac, and it hooks up to the suction. And also hospitals have them on the walls. And what the nurse does is she goes and she brushes their teeth, but it also suctions all the secretions, which the biggest problem with the secretions that they have is aspiration pneumonia. And my dad was in the hospital 2 years ago. And interesting enough, he was in a coma. And I just shut the door and I cleaned his mouth with the suction toothbrush. And you can actually buy this. It's called Plaque Vac for our patients. And you can buy it on Amazon. But this is something that works really well. Sometimes they use a toothette, which looks like a lollipop. And they put a little chlorhexidine and wipe it on, their teeth. But this is really the best thing, this suction toothbrush. And it should be used a couple times a day. And because of those secretions and the bacteria really reduces the risk of aspiration pneumonia.
And having Karen answer that question is such a good thing because it really shows the value in working with your hygienists. Hygienists are educated professionals. Hygienists have so much knowledge, especially when it comes to oral hygiene. So if you get a question and a question is posed to you and you may or may not know the best answer, make sure that you run that by your hygienist as well, especially when it comes to oral care. My hygienists have come up with some really, really good ideas. Karen's taught me a ton of stuff. Next time I come to Arizona, Karen, I'd like you to brush my teeth with that plaque vac. Well, maybe not that one, because you probably use it on all sorts of demos. Maybe I'll buy another one and you can brush my teeth with a different plaque vac. But I want to know how that feels. That sounds cool. But thank you for that answer. And I think that that's a good thing for all dental students to think about, is when you come out, you will be working with other professionals. You'll be working with assistants. You'll be working with parents. You'll be working with hygienists. And make sure that you look to all of those sources to get ideas and what different things you can do. So excellent answer.
Thank you guys for coming. I know I definitely appreciated it and I learned a lot. And I'm sure everybody else who's camera shy did too.
Thank you, panelists. Thank you, everybody. Big round of applause for the panelists, because they all donated their time. No one is being paid for doing this. And so thank you to everybody for donating your time to help these students have more exposure to our wonderful patients and how we treat them. And I appreciate all of you guys for being here as students. I appreciate Emma for putting it together, Dr. Costin for introducing us. And again, my heart to all of my friends and panelists for being so supportive with this.